We're talking about CKD and type 2 diabetes. They are usually associated together, all of you know about it. Various surveys done across the length and breadth of our country, including one pan-India survey which we did, longitudinal study, 3,000 patients across the country. About 45 to 50% of the type 2 diabetic patients have chronic renal failure. You call it a comorbidity in some conditions, you call it a complication in some other condition, but the fact that it stays together along with type 2 diabetes. And when both together are there, the macro and microvascular complications, including the renal complication, go down the line in very rapid manner, reducing the longevity, and more important than the reducing the longevity is the reducing the quality of life, which we don't want. So our idea is, in a type 2 diabetic patient, we have to prevent CKD as far as possible. Obviously, we can't prevent in everybody. In that case, we have to detect it in those who already have as early as possible. And once we have diagnosed CKD, we have to treat it aggressively so that it doesn't progress and it doesn't produce long-term complications or to slow down the long-term complications. As 90% of patients in our country are treated by family physicians, they have certain questions because of which, or certain misunderstandings, because of which they are not able to do the optimal use of very effective drugs like SGLT2 inhibitors and other drugs which are now available in a day-to-day practice. They have a lot of questions in their mind. So today I am going to solve these questions. The questions are, is it essential to assess albuminuria and eGFR in all the settings? What are the possible trajectories and implications of renal functions in diabetes, decline in renal functions in diabetes? What is the optimum point of intervention with SGLT2 inhibitors in the progressive course of chronic renal disease? How should stewardship be optimized for SGLT2 inhibitors used in CKD? How we remove the blocks in their mind, misconception in their mind, and give them the correct information? And what are the guidelines saying? Now let's start with the first question. Is it essential to assess albuminuria as well as eGFR in every person? Now this slide clearly tells you that in patients without prior comorbidities and in patients with prior comorbidities, both albuminuria and declining eGFR are independently associated with higher risk. And the risk is far higher than the other risk factors which you feel are important, like systolic blood pressure, diastolic blood pressure, dyslipidemia. But the risks associated independently with eGFR as well as albuminuria is much higher in those who do not have comorbidities as well as those who have more comorbidities. So obviously both of them are important, both of them represent different aspects of chronic renal failure, and we have to investigate them in every patient. Now worsening of eGFR as well as albuminuria level represents worsening prognosis of cardiorenal events, hospitalization and death. What all these four squares are telling, that if you study the cardiovascular mortality in type 2DM with renal impairment, kidney failure and need for renal replacement therapy, heart failure and hospitalization for any cause, you take eGFR which is mildly low, almost normal. But even in all those patients with mildly low or almost normal eGFR, as albuminuria increases, the risk increases for all these factors. Similarly, if you have normal albuminuria in all a cohort of patients, but in different patients have different deteriorating renal functions as assessed by eGFR, as the eGFR reduces, the risk increases. So both of them are again independently important. Now CKD is defined as abnormalities of kidney structure or function present for minimum of 3 months. This is very important. One abnormal albuminuria or abnormal albumin creatinine ratio is not a CKD. Once you get a eGFR of 55, it is not a CKD. It has to be persistent over 3 months, and repeat investigations done after 3 months also should show deteriorated EGFR. You need not have both together. You can have chronic renal failure if there is a persistent albuminuria without reduction in EGFR, and you can have a chronic renal failure with reducing EGFR without albuminuria. So either EGFR is low with normal albuminuria, or albuminuria is high with a normal or mildly affected EGFR. In both the conditions, it is chronic renal failure, but both of them together, obviously the risk is very high. So chronic renal failure is important. It worsens the prognosis, cuts short the life, reduces the quality of life in type 2 diabetes patients, and our job is to prevent it or at least diagnose as early as possible. So we must know how do we diagnose it. What are the criteria? What are the guidelines? In type 1 diabetes patients, 5 years after the diagnosis of diabetes, which is equivalent to 5 years after the onset of diabetes, because there is hardly any gap between onset and diagnosis, as you know, you should do first screening for renal impairment. But in a type 2 diabetes patient, the first screening should be done immediately after the diagnosis of diabetes, because type 2 diabetes can remain silent up to 5 years. What you will do spot urine ACR, and you will also do EGFR. I told you why we require both. If they are abnormal, look for the temporary causes like fever, excessive exercise, etc., very high blood glucose, etc., etc. Tackle them, repeat it after 3 months, and at the end of 3 months again, if the figures are abnormal, then this is chronic renal failure. What defines CKD? Persistent urine ACR equal to or about 30 mg per gram, and or persistent EGFR less than 60. And of course, if there is a structural damage as picked up by imaging technique, or a biopsy has been done and it proves that there is a renal damage, this is chronic renal failure. Now let us look at this prototype of man. 50-year-old person, type 2 diabetes, 1 year, long-standing hypertension, long-standing dyslipidemia. You take any parameter for glycemic control, it is poor, he is overweight, his blood pressure is high, his LDL cholesterol is high, he already has UACR 90, which is quite moderately high, serum creatinine borderline. He already has positive treadmill stress test and is currently on metformin, telmisartan, amlodipine, hydrochlorothiazide, atorvastatin, all good drugs. But the main drug is missing to prevent the further deterioration in renal function and protect the patient from atherosclerotic cardiovascular disease is missing. Now this man has reduced EGFR and also has moderately increased albuminuria, and both together he has a high risk for further deterioration of renal functions and reaching chronic renal failures, reaching end-stage renal failure stage, as well as other cardiovascular complications. So one of them is sufficient to diagnose chronic renal failure, but when both of them are there, the risk increases tremendously, as this man is placed as high-risk patient. Next question, what are the possible trajectories and implications of kidney function in decline in type 2 diabetes? You know, there are different ways in which a patient with chronic renal failure in T2DM will progress. One of the commonest ways is trajectory number 1. He will have a persistent albuminuria with slight deterioration over a period of time, and after some time he will have a very rapid deterioration of EGFR and moderately slow progression towards the end stage renal failure. In trajectory 2, regression of albuminuria with treatment, that is also possible. He reduces weight, he controls his blood pressure, he controls his blood glucose, takes proper drugs like SGLT2 inhibitors, last blockers, he can go back to normal albuminuria also. A category 3 is very time seen in our country, is a rapid decline in renal function, rapidly declining EGFR and rapidly declining albuminuria state. And category 4 is non-proteinuric DKD with slower decline in EGFR. And that is another reason why you should be consistently measuring both of them. So a given patient may follow any of these processes. Chronic diabetes, long-standing diabetes, or even presence of diabetes itself is associated with greater risk of rapid EGFR decline as compared to those who are non-diabetic, and among diabetic, those who are having diabetes for a shorter time. And more rapid EGFR decline is associated with increased long-term risk of major macrovascular as well as microvascular complication and mortality, as shown in advanced trial. So, and similarly, A rapid EGFR decline also associated with its bad effect on heart failure fund with 3.2 times more common odds for heart failure. So those who are declining, whose EGFR is declining rapidly, will have more macrovascular disease, more microvascular disease, and more heart failure. Now let's go to the third question. What is the optimum point of time for intervention for SGLT2 inhibitors? Now, this is that EMPA-KIDNey trial. EMPA-KIDNey trial was cardiovascular outcome study. The intention was it to get the permission for the product to be launched as per the government of America's rule. 2008, 2009, any new drug coming into the American market has to prove that it is safe for heart. So this study, the very famous study, was done with limited idea of proving safety on heart of EMPA-KIDNey. But when they spent billions of dollars across multiple continents in thousands of patients, naturally they put on some secondary endpoints. And they not only proved safety on the heart front, they proved that it is very effective to protect the heart. But on the secondary endpoints, a very surprising finding was it also showed that 39% relative risk reduction for worsening of nephropathy, 38% relative risk reduction for development of macroalbuminuria, and 46% relative risk reduction for time taken to double the time for chronic renal failure patient. So on the side, they proved that it is very safe and renoprotective. Empagliflozin prevents rapid EGFR decline consistently across the renoprotective effect was not only seen in those who had a moderate renal failure to start with, it was also seen in those patients who did not have renal failure. Patients with prior microalbuminuria, it was possible to regress to normal albuminuria, and patients with prior macroalbuminuria regress to either normal albuminuria or microalbuminuria. And just like EMPA-KIDNey, the other cardiovascular outcome studies where primary aim was merely to prove the safety of drugs on heart, they all ended up proving very effective renoprotective effect. Canagliflozin, dapagliflozin, all of them proved. Once this was a very positive, surprising findings, that by that time cardiologists were already saying that this is our drug, we are going to use it as a frontline drug in heart failure and atherosclerotic cardiovascular disease. Renal nephrologists started thinking about it. Why don't we have a specifically designed renal outcome studies? And EMPA-KIDNey is a specifically designed renal outcome study, just like a DAPA CKD and just like trial done for canagliflozin. Now, what was the difference between these three renal outcome studies? EMPA-KIDNey study, which was the last study to be published, it was published just about 6-7 months back or maybe a little more. It was done, it included patients with lowest EGFR, they went up to 20. It included diabetics as well as non-diabetics, 50% of the patients were non-diabetic renal failure. It included different types of etiologies for renal failure, whereas the other two studies on dapagliflozin and canagliflozin was purely diabetic kidney disease. And the most important thing is, it also included those patients who did not have a significant albuminuria, whereas other studies mandated that the patient should have albuminuria as well as low GFR. So in this study, the empagliflozin significantly proved that it reduces the risk of end-stage kidney disease. And it shows the rate of EGFR decline by half in patients with CKD, again across the different kidney functions. It worked very well in those who had a mild renal impairment as well as in those who had a more significant renal impairment. And if used properly right from the beginning, it can do a lot of wonders, like it may reduce the chances of hemodialysis, prolong the life, chances of other complications, and so on. Now let us go, this is a very important question. A family doctor should remember that when you start SGLT2 inhibitor, you should expect some decline in EGFR up to 30% initially. within first 3 to 6 weeks, it comes to back to within 3 months, and then it starts improving. So don't worry if there is a small reduction in EGFR is not associated, there is not indication to stop the products. I'll show you a trial. This is the trial in which those who had initially a bigger drop of EGFR, they had also got an equal protection from those who did not have EGFR. Clinical benefits of empagliflozin significantly outweigh the risk in more frail patients. Another thing is many people are afraid to use it in frail patients. They think that it will have a postural hypotension, he will fall, he will have a fractured neck femur, and so many other things. But if you select them properly, you prevent their dehydration, you stabilize their blood pressure, reduce the diuretics, the trials have shown that they get more benefits as compared to the non-frail patients in the management of CKD and other complications. Incidence of urinary tract infection and fungal infection. Yes, it is a little bit more common. Yes, it is even more common in females than in males. Yes, it is even more common in sultry atmosphere of Mumbai. But that doesn't mean we should not try this drug. If taken care, if you have a proper hygiene, you can use it in many of the patients. Where to stop? I'll straight away go to this slide. Mild bacteriuria without any symptom is not a contraindication for use of SGLT2 inhibitors. Past urinary tract infection is not a contraindication for urinary. Just 2 minutes more. Similarly, if somebody has the urinary tract infection or a fungal infection, you can treat it properly and then restart using it. It doesn't mean that the patient may not be able to use it again. And even in those patients who had some serious side effects, you can always control them and then again try. But there are certain contraindications in which you should not use it. And the last slide I will tell you is SGLT2 inhibitor use, need for CKD monitoring and treatment cessation, importance of restarting SGLT2 inhibitors after planned discontinuation. I think I have already told you, suppose somebody you had to stop it, he had nausea, vomiting, he was having recurrent infections or something, acute infection, you can stop it, settle him. After everything is steady, after he starts eating it, you can restart using it. So, because these drugs provide you so many renal and cardiac benefits in addition to glycemic benefits, blood pressure benefits, you have to try your best to give them to the most of the patient. High risk doesn't mean that you should never use it. You should use it properly. I've tried to give you some guidelines when to use it, but of course there are certain contraindications where you cannot use it. But the time is so short that I can't cover it now. Thank you very much.